Hello, and thank you for having me. My name is Phillip Abarca, and on behalf of my co-authors at the Keck School of Medicine of USC and Los Angeles General Medical Center, I'm excited to share with you our work entitled Accuracy and Correlation of Bed and Standing Scale Weights in Monitoring Volume Status in Heart Failure Patients. For some context, heart failure affects roughly 6.5 million Americans, with over 1 million hospital admissions for acute decompensation each year. This results in almost $40 billion in healthcare costs annually, and unfortunately, heart failure decompensation is the most common cause of Medicare readmissions, with a 30-day readmission rate of roughly 23%. Controlling volume status is vital in the management of heart failure decompensation, and current ACC-AHA guidelines recommend obtaining standing body weights during hospitalization to monitor heart failure treatment response. Despite these clear guidelines, bed scales are commonly substituted for inpatient weights in the inpatient setting. This can be due to a number of reasons, including mobility orders that limit standing and ambulation due to concerns over fall risk, recent sedation also requiring those mobility orders, or even medical equipment that limits mobility, including intra-aortic balloon pumps, indwelling Foley catheters, or bladder or non-invasive urinary collection containment systems. While limited data does exist assessing the accuracy of bed scales, which are commonly substituted compared to standing scales, there is a concern that large discrepancies between the two do exist. And this is concerning as there are clinical consequences to having inaccurate weights, which may lead to errors in medication dosages, unreliable volume assessments, and potentially inappropriate discharges. In order to quantify the difference between bed scale and standing scale weights and decide whether that gap could potentially impact clinical decisions, we decided to develop a novel study to compare and quantify differences in standing and bed scales in patients hospitalized for acute on chronic decompensated heart failure. This study was a single-center, prospective, method comparison study at a Level 1 academic trauma center and safety net hospital. Participants were adults who were older than 18 years of age, admitted for acute decompensated heart failure between March and April of 2023. As part of the inclusion criteria, they must have medical clearance to mobilize out of bed and demonstrate the ability to mobilize and stand independently. Participants were sequentially weighed on both bed and standing scales, and the bed and standing scale weights were then compared. Now, prior to the conduction of the study, standing scales were not a clinical tool that was available at Los Angeles General Medical Center. Due to resource limitations, patients were being weighed exclusively on bed scales due to the lack of standing scales. The standing scale intervention was able to be made possible through a quality improvement grant through our CIR resident union. These scales were implemented in the cardiac intensive care, progressive care, and telemetry units, which serve our cardiac patients. This intervention required a multidisciplinary campaign with physicians and nursing leaders in these units in order to implement the standing weights into nursing workflows. During the course of this campaign, a number of concerns to nursing workflows and patient safety issues were both voiced and addressed, and highlights the need for quality improvement methods to incorporate cultural changes when changes are being implemented. Regarding the statistical analysis for the study, a power analysis was performed which revealed that 44 paired weights were needed to detect a clinically meaningful difference of 0.6 kilograms with an alpha value of 0.05 and 80% power. Ultimately, 51 paired weights were obtained, raising the power to 0.86. Standard descriptive analytics were performed. The mean weight difference, which was bias, our precision, our standard deviation, and the limits of agreement, 2 standard deviations, were calculated and graphed using the Bland-Altman method. In all, 43 patients had a mean age of 62 years with a range of 13. 65% of them were male, and the majority of them, 81%, identified as Hispanic. This is reflective of the safety net population that the Los Angeles General Medical Center serves, which is a predominantly low-income Hispanic community. Standing weight values ranged from 43.4 to 117 kilograms, with a mean of 74 kilograms. The difference in weights observed was 1.42, with a standard deviation of 1.18 kilograms, giving a 95% confidence interval of negative 0.894 to 3.73 kilograms, exceeding our recommended bias value that was predetermined. Saying it another way, when we subtract the standing weights from the bed weights, we see a systematic bias of 1.42 kilograms, and our precision is represented by the standard deviation of 1.18. Translating this into clinical practice, 71% of our paired measurements exceeded our 0.6 kilogram action threshold. 22% of them overshot this by more than 2 kilograms, and 6% of them by more than 4 kilograms. You can see in our bland Altman plot in the top right that nearly the entire data point cloud sits above the 0 line. In other words, the bed scale almost always overreads the weight of the patient, and often by amounts that are large enough to change how we manage diuretics or decide on discharge readiness. While bed scale weights were precise, they produced inaccurate weights compared with standing scale weights in our study. A number of factors may contribute to why this is the case, including extraneous items left on patients' bed, like their personal belongings or other medical equipment, transfers between beds with different calibrations as they move through different levels of care in the hospital, inaccurate calibrations, as well as inconsistent weight collection practices between both nurses and nursing units. This is important because in heart failure, small differences in weight, such as a 0.9 kilogram weight gain, can result in a need for a hospital readmission, and this is well within our mean error of 1.42 kilograms. Dry weights are obtained on discharge, and they're used to inform our management practices in the outpatient setting. Overestimations of this weight can lead to underdiuresis, premature discharge, and early readmissions. And while not seen in our patient population, underestimations of their weight may do the opposite, risking renal injury and hypotension in the future. There are some notable limitations to our study. In general, the generalizability is limited given our single institution in which it occurred, a limited number of nursing units in which this study occurred, as well as a limitation of a single brand of both bed scales and standing scales. Additionally, as part of the methods of our study, the bed scales were not recalibrated each time that our patients were assessed in order to better reflect real-world practice patterns in our nursing units. While this was part of the design, calibrating the bed scales may have changed the outcomes of this study. Now, where do we go from here? I think the study highlights the opportunities that we have to optimize the systems-based practices that we use to improve management of patients with decompensated heart failure. At my medical center, there are needs that exist to improve the accuracy of weight measurement, including standardizing bed weight measurement methods and educating nursing staff to obtain standing weights in lieu of bed scale weights, which are more often preferred. Accurate weight data is vital to guide outpatient heart failure management, and using inpatient weight measurement as an opportunity to both educate and inform our patients on outpatient behavioral patterns is a significant need. Additionally, remote weight measurement is an opportunity that we have in the heart failure community to improve outpatient patient monitoring and prevent readmissions. Now, in conclusion, heart failure is a common condition, and readmissions are a major burden on the American healthcare system and across the world. Accurate weight measurement to guide volume status is essential to reduce hospitalization duration and to prevent future readmissions. Guidelines recommend daily monitoring of standing body weights, though hospitals use bed scales instead for a number of reasons. This study compared weights obtained via bed and standing scales among patients hospitalized with acute decompensated heart failure. It was found that bed scale weights were precise but inaccurate when compared to standing scale weights, potentially leading to errors in clinical management. In fact, bed scales overestimated weights by patients by a clinically meaningful 1.4 kilograms, and 7 out of 10 patients showed errors that were above these action thresholds. As a result, whenever patients can safely stand, even if they require some minimal assistance, standing scales should be used to obtain patient weights. For bedbound patients, improvements should be made in protocols to obtain accurate weights. This study wouldn't have been possible without the generous contribution from the CIR Union and the Quality Improvement Committee. I also want to thank the other members of the research team, including Devin Skoll, a medical student at the time, now a medical resident in New York, who really pioneered the study's design as well as conduction, as well as our research mentor, Dr. Michael Fong, and Dr. Helga Van Hurley, the Cardiology Fellowship Program Director, who was instrumental in obtaining the standing scales as well. I want to thank the nursing teams of Los Angeles General Medical Center, who are on the front lines day in, day out, obtaining these weights to allow us to take care of our patients. And lastly, and always, I want to thank the patients of Los Angeles County, who serve us far more than we serve them. Thank you.